Hi, everyone. Welcome to episode 4 of the Inside Implementation Realize webinar series. Today, we'll discuss strengthening NCD programs in India from experiences in the states of Kerala and Tamil Nadu. I'm pleased to introduce our moderator for this session, Dr. Pragati Hebbar. Dr. Pragati brings over a decade of interdisciplinary experience spanning research, policy engagement, program implementation, and capacity building. She's trained as a dental surgeon with a PhD in public health from Maastricht University. Her ongoing work through a DBT Wellcome Trust India Alliance Fellowship focuses on implementation research and realist research. Her interests lie in bridging research and practice, fostering compassionate leadership, and supporting institutional transformation. She's currently serving as the regional board member of the Health Systems Global for the Southeast Asia region, and she is dean at the T.T. Narasimhan School of Advanced Studies at IPH Bengaluru. Over to you, Dr. Pragati.
Thank you, Arushi, and a very warm welcome, everyone, to this episode of Inside Implementation. It's an absolute pleasure for us to have this interaction with the deputy directors from Kerala as well as Karnataka and from a senior researcher. So the purpose of these dialogues has been to bring people from different backgrounds and have these conversations, mainly focusing on implementation research on non-communicable disease control, etc. So it is an honor and pleasure to introduce Dr. Bipin K. Gopal, who is a public health specialist and the Deputy Director and State Nodal Officer of NCDs from the government of Kerala. And he's been leading key programs in NCDs like cancer care, palliative care, and tobacco control. So he has worked extensively in the decentralization of healthcare delivery, including innovative models for stroke care, diabetic retinopathy screening, and COPD management. His work has significantly strengthened primary care systems and expanded community-based palliative care to over 1.5 lakh patients. So Dr. Bipin is a nationally and internationally recognized leader with multiple awards, one of the most recent ones including the UN recognition in 2020 for leading NCD control programs in Kerala. So thank you, Dr. Bipin, for joining us and making the time for this interaction. Yes. So maybe we'll go ahead with engaging the speakers one by one. So I will start with a few questions to you, Dr. Bipin. And even as we registered for this webinar, the audience also has many questions that they would like to engage with. So to start with, are there any best practices or lessons, like any models of care that have been most effective in your context in Kerala? And if you could briefly share about that. Thank you.
Thank you, Madam. Thank you, Pragati, Madam. And thank you once again, Indian Institute of Public Health, Bangalore, for giving me this opportunity. So at the outset, let me tell you that the most innovative model that we have been practicing in Kerala is the life course approach that has been taken place in the NCD control. Right from the community level to the tertiary hospital, right from the community to the primary care system, to the secondary level system, and to the tertiary care system, we have strengthened our NCD control program. So at the community level, we have the ASHAs who are doing a community-based assessment through a population-based screening. So the first initial phase of screening happens at the community level. And we have given them an application, a mobile Android application, through which they will enter the health data of the people above 30 years of age. So from that data, we can analyze who are all in need of NCD care, who are all are in the risk of having NCDs. So there is a scoring system called the community-based assessment checklist scoring. And if that score is above 4, they are bound to have some kind of a non-communicable disease, and they will be subjected to screening. So the first level of screening happens at the sub-center level, that is at the HWC, the Health and Wellness Center, or the ARM. And there we have the junior public health nurse, the uh, junior health inspector, and also the CHO or the middle level service provider. They will do the initial screening for the hypertension, for diabetes, and for the basic cancers like the breast cancer, cervical cancer, and the oral cancer. And the screened positive patients will be referred to the nearest PHC for confirmation. And at the PHC, there is a staff nurse and the medical officer who will do the confirmation. And if it is diabetes or hypertension, the initial treatment will be started there. The entire medicines, including insulins, will be provided at the primary care center. And if it is cancers, the breast, cervical, or oral cancer, the first level of confirmation will be done at the primary care center, and then the patient will be referred to the secondary care hospital for the further lab investigations and management. And from there, the patient will go to the district level hospital or to the regional cancer centers for the treatment. So this is a course which starts from the community down to the medical colleges or the regional cancer centers. So this is the model which we are practicing right now. And every year we are doing this population-based screening, and nearly 90 to 95% of the total population are screened every year. And those who are found out from the screening are referred to the nearest facility, and further diagnosis will be made and the treatment will be made. So this is the overall model of the NCD control program in Kerala, which we can say as an unique model, which start from the community up to the medical colleges. And it's an innovative model. There are other diseases also which are covered under this NCD program. Those are the COPD, which we have a program called the SHWAS program, which actually screens for COPD in the respiratory illness patients and gives the management also at the primary care level. Then we have a program for diabetic retinopathy, where we use a camera to identify we will take a fundus photography and we'll identify three diagnoses. One is diabetic retinopathy, the second one is glaucoma, and third one is adult maculopathy. So three diagnoses are done using this camera. So this also happens at the primary care level, not at the main hospitals. And we have stabilized the cancer screening, decentralized cancer screening program at the periphery level. And we have cancer treatment facilities at the sub-district level hospitals and district level hospitals. Nearly 28 of our hospitals are having treatment facilities for cancer. And we have stroke facilities, stroke treatment facilities in our 28 of our hospitals. And we have cath lab in all the district level hospitals. So these are the main NCD achievements we do have in a nutshell.
Thank you. Thank you so much for sharing that. And it gives a good picture of how the life course model has been applied at various levels. And also the kind of the different components, the infrastructure, the screening, the capacity building, all of that in a nutshell. Being researchers ourselves, I would like to pose the second question on how does what kind of research do you think helps fine tune or improve the program implementation? So do you have like what is the kind of research that is helping you or guiding you? And if you would like further research to happen, what would be most beneficial to system actors in improving the program implementation?
Even though I told that there are innovative models in Kerala for diabetes, for hypertension, for cancers, for COPD and all, these are not foolproof models. There are still gaps existing within this system. So an operational research into every of these programs will definitely help us to find the gaps in the system and how we can improve this to cater more people and have a more qualitative approach. So the operational research is one of the main things that we can involve. And the second thing is that even though we are giving instructions from top to bottom for the management of the major diseases at the primary care level, we actually doesn't know the actual knowledge, attitude, and practice of the people who are down there who are actually implementing this job. So a KAP would definitely help us in understanding the level of knowledge that every primary care uh, functionaries are having at the desk, because they are the people who are actually carrying on this work. So if they don't have that attitude, if they don't have that knowledge, these programs are not going to get success. So such a knowledge and a CAP study is definitely going to help us in this. And the third kind of study is which we actually require is that even though we are providing medicines up to primary care level, the control rate of these diseases, diabetes, hypertension, and all, are still below 50%. It was nearly, it was below 20% when we started this program, but gradually there was an increase in the control rates. What I mean by control rate is that the control, the rates of hypertension, the rates of blood pressure, and the blood sugar value after putting a putting a patient on treatment for 6 months time. So when we put a patient on treatment today, after 6 months, what will be this value? So that is the control rate. So that control rate is still hovering near 40% and 36% for hypertension and diabetes respectively. So why is not, even though we are providing all kinds of medicine, all kinds of treatment, why is not that control rates getting improved? So we have to do a study at the population level. So what are the factors that are hindering the increase in control rate? Is it the lifestyle practices that are still being followed up? Is it the quality of medicines that they're taking? Is it the compliance to the drugs that we are providing? So there are many factors which are still there in the field, which needs to be understood. Then only we can have a steady control rate of above 80% or above 70%. So there we need to have a detailed study at the field level. So these are the some areas which I feel we need to have a research on.
Sure. Thank you. Thank you so much for sharing right from the actors, the system actors, but also the population and the kind of studies that might help program implementers. Lastly, if there are like 2 or 3 priority areas that you see for NCD control in Kerala for the next 3 to 5 years, what would they be, sir?
The first priority area, I definitely would think that because we are the capital of diabetes, we are the capital of hypertension. Nearly 24% of the total adults are diabetic, and 14% is pre-diabetic, and 38% of the population is hypertensive. So the control of hypertension and diabetes would be the main priority, because it is because of these basic diseases that other NCDs are also increasing, like the complications like the heart disease, the heart attacks, the dialysis, which are happening, the end-stage renal diseases. So the basic cause of these major diseases are the control of hypertension and diabetes. So that holds the important key to the success in hypertension and for the control of non-communicable diseases. The second major area is the increase in cancers in the state, especially the increase in breast cancer and the high mortality in the cervical cancer. So that also holds the key for the future activities. So these are the two main areas which I feel in Kerala it's very important.
Thank you. Thank you for sharing. And I think now with the increasing need to move also beyond, say, diabetes and hypertension and to bring that focus onto cancer also, I think is been discussed in quite a few fora. So it's great to see that that's also the direction in which, in Kerala, the plans are proceeding. I just quickly looked at the participant list, and we were hoping that Dr. Raghunandan would be able to join us, but there was a slight uncertainty in today's schedule on his side. And hence, we had also taken a recording of the conversations from the Karnataka Karnataka side. So I will request my colleague Arushi to play that. And after I introduce Dr. Raghunandan, who is he's a seasoned public health leader with 2 decades of experience in Karnataka's Health and Family Welfare Department and is currently serving as the Deputy Director, Non-Communicable Diseases. He has led key leadership roles across district and state levels, mainly driving major public health programs and system improvements across mental health, TB control, leprosy, and his contributions were also recognized by the government of Karnataka through the Best District TB Control Officer Award in 2010. So, with that, I would request Arushi to play the recorded version of the interaction. Thank you.
What models of care in Karnataka, for example, community-based care, PHC-led care, or task shifting, have been most, helpful in the state?
Actually, Karnataka, we have adopted continuum care models of integration of these programs. Basically, we have so many models we are using. Among the important models we are using is Ayushman Arogya Mandir based model, where we have strengthened. It is a first point contact for screening of all the primary health care. So we are equipping with the AIM, with the trained staff, and a screening tool and essential NCD drugs also providing there only. So for more accessible and especially in the rural areas. And we are using the CBAC forum for risk assessment tool at the AIM level only. So this is the one model we are using in the Karnataka state. And other model is a hub and spoke method we are using. So hub and spoke method we are mainly using for our STEMI program and even in chemotherapy, that is daycare chemotherapy centers, we are started, already established. These two areas we are using the hub and spoke model for the referral of the patients and we are using the telemedicine facility for the linkage of specialist, and also we are using a NCD clinic and a district hospital for the referral screening. So these are the important models we are using in presently in Karnataka state.
Thank you, sir, for highlighting the aspect of continuum of care, which is something that the state has really been focusing on. And I have another question, sir. Since a lot of our audience members are researchers and implementers and practitioners in their own right, we wanted to hear from you, sir. What kinds of research or evidence would be most useful for you in the state to improve or scale NCD interventions?
It's a very good question because data and evidence must guide every step of the program to implement. So, in my aspect, in the implementation research should be the one of the method to adopt in the this one NCD program. So in this, we need to research and evaluate a real implementation of NCD intervention. In this regard, already ICM are doing some of the study. They are selected as some of the district. In Karnataka, they are selected Mangalore district, Dakshina Kannada district, they are selected. So overall country, they have selected 11 districts to know the program implementation. They are doing the implementation research only. So the day before yesterday, I am the part of ICMR team also for regarding this research activities only. Anyway, they are doing it this one. So one of the important is implementation research is the one of the important, and second is a cost-effective study because, for example, mobile screening unit versus fixed site services, these are the two aspects. So it will help us to locate the fund allocation for the fund allocation for more effective program implementation. So in research activity, this cost effective study also should be taken care of, this one. And there are many other health system redressal assessment is there. So we have to do this one also. And mainly we have to do the integration of NCD services with the existing health program and digital health platform you have to use for the research activities also. So these are the important research activities we have to concentrate for the NCD program.
Thank you, sir. That was really helpful in terms of not just the methods that we use like you rightly mentioned, implementation research would be very important to guide our future actions related to policy implementation. And also, thank you for highlighting practical aspects related to how project management and research would work in terms of understanding cost effectiveness studies, etc. And also for discussing how integration of the program, not just to other sectors, but other departments, and how we can include the use of digital tools for that we already use for monitoring and evaluation, and build more research questions in that lens, sir. My last question to you, sir, is a bit more looking towards the future, I would say. What do you think are the key strategic priorities for NCD control in Karnataka over, say, the next 5 years?
In this regard, actually, we are implementing a one program called Groha Arogya in Karnataka. This is basically NP-NCD program only. According to Government of India, we have to take up for 5 diseases, that is hypertension, diabetes, and 3 common cancers. But in Karnataka, we are doing a Groha Arogya implementation. Along with 5 diseases, we are added another 9 diseases for the same program. So in Karnataka, in NP-NCD program, we have called it as Groha Arogya. In this Groha Arogya, we included totally 14 diseases. So all these are NCD related diseases only. So we are concentrating in this aspect, and we are implementing from this month onwards. So this is one of the major strategic priority for our Karnataka state. So this 14 diseases include our five from Government of India, that is hypertension, diabetes, and 3 common cancers, along with 9 other comprises of one is diabetic foot. It is a neglected part of this one NCD program. So we are included this one. And we have a diabetic retinopathy. This is also in all the cases will be diagnosed in the later stage. So we are included in this screening, and this one priority area we are taken as a priority sector. And we have a this one COPD. We are included in the COPD. CKD is also included in our Groha Arogya program. We have obstetric sleep apnea. Even this one also you are added in the priority list of our NCD control program. Along with this, even mental disorders and neurological disorders also been included in the part of NCD program, that is Groha Arogya program. So these are the total 14 diseases, including anemia also you are included in this program. So totally we have 14 diseases under Groha Arogya program for the NCD control. So this is our first strategic priority for the NCD for the long-term process. And our second NCD program for the first next 5 years include, we are expanding the universal screening for all the hypertension, diabetes, and common cancers through HWC and outreach activities. These are our second priority area. And we are strengthening the primary healthcare fully by organizing the health and wellness cancer trained staff and protocol drugs and diagnostics and other essential drugs. And we are ensuring the continuum care through the effective referral mechanism and follow-up of the patient's mechanism. These are our priority area. And we are also looking for investigating in the digital tool like a NCD portal and real-time tracking and data-driven planning. We have a priority area, and we are promoting health. Promoting the health lifestyle activities. This is also very important in the control of NCD program. So another program is already I told, we are integrating the mental health and even the elderly care also. We are integrating with the NCD services only. And we are focusing on more also regarding the urban NCD care. Right now, we are focusing only on rural. So we are focusing in next, our priority is focusing on the urban NCD care also. And improving the capacity building is also one of the criteria. And ensuring the convergence and sustainable financing for the long-term program success. So these are the priority area for considering for the next 5 years. So overall, our goal is to reduce the NCD burden while improving the access, equity, and quality of care across the Karnataka state. This is our motto of our goal, and also for this priority area.
Thanks, Arushi, for playing that. So now with that, I'd like to invite our third speaker for the day. It's my pleasure to introduce you all to Dr. Tanya Seshadri. She's my senior colleague at the Institute of Public Health and is a medical doctor with specialization in community medicine from CMC Vellore. She has over 15 years of experience in public health, particularly in partnership with Solika Adivasi people in southern Karnataka, where she also leads the Center for Adivasi Health of our institute. Her training has included managing community based secondary care services with a focus on maternal and child health. And she has been honored with the T.N. Koshu Memorial Award in 2021 for her public health contributions, and also named as a change maker by the Deccan Herald in 2022. Thanks a lot, Tanya, for making the time to join us today. So yeah, to start with, and since you bring a different perspective, I would like to understand from you that in the overall framing of the NPNCD program, do you, and based mainly since you're based and a lot of your work is at the district level within a southern Indian district, do you see any challenges or issues on how the program itself is framed?
Yeah, thanks a lot. Just one disclaimer, I'm joining from a forest area, so in case I have network problems, I'll turn my video off. Um, really nice to hear both the Kerala and the Karnataka deputy directors talk about the programs. And it's true, I think a lot has happened in the NCD space. Working with the Adivasi people in South Karnataka, I mean, one would assume that in the government, in the public health system, we do a lot of things well, like maternity, RCH, TB program, etc. But when it comes to Adivasi communities, even access to these services in the way it is imagined is not necessarily happening fully. And so when it comes to NCD, you would imagine that, or any chronic condition, that would be a struggle. But interestingly, we see that when it comes to the NCD, for the first time, communities actually have access to a conversation around chronic conditions, because most of the time NCDs was diabetes, hypertension, stroke, etc. were conversations that, I mean, were required in the community but were only accessible in the secondary hospital beyond phase, and then later in the primary health centers. Now with health and wellness centers and CHOs, ASHA, ANMs, that conversation coming into, like, and Sir was talking about the Griha Arogya program. So as it is coming closer to the communities, we see that now whatever access people have to medication, to diagnosis, to even counseling is now slowly actually being made available for Adivasi people because it is coming closer into the community and it is becoming part of the larger health system. So I think that is welcome. But some of the challenges we very clearly see is that the program brings with itself the larger definitions that come from the majoritarian epidemiology, that of whatever information we have. For example, with the Soliga people, we hardly see type 2 diabetes. But we do see type 1 diabetes cases. We see type 5 diabetes cases. The numbers are not big. Community is also scattered. But for type 1 diabetes or type 5 diabetes, where you have younger age group, pediatric age groups, again, the primary healthcare system, even secondary hospitals, sometimes even medical colleges are not very clear from a program perspective. You ultimately have to depend on the clinician in the tertiary medical college and what they're able to do. So there are some specific asks here from the NCD program that are very important and relevant. We lose children to diabetic ketoacidosis at least once in every 2 years, only because the diagnosis is something that they do not look for. So what kind of chronic conditions are we looking at, or how do we change what we are doing in these spaces? That kind of thinking doesn't exist. We see a lot of hypertensive cases, nearly in one of the studies in a 17 hamlet region where IPH works, they see about 15% of the people in the community, about 30 having hypertension. But we see a lot of hypertension amongst women as well, and as early as 30, 31, 32. But the epidemiology of this, these are young, fit people going for work, eating whatever is available to them, not too much control over what they can eat or over their day itself. But we are treating them in the same way with the same logic of the routine hypertension. So many of them, they do not know, it does not come into control. So even the existing programs and the way the design happens needs to be thought a little bit more. And if we don't know about it, since you are asking the question of research, then I think these are very clear issues that have been flagged. Now, across India, there have been some studies, like it's known in Assam with tribal people working in estates, tea estates, that they have a very high prevalence of hypertension, and this has been associated with their lifestyle during their work. So like this, there's probably a need to have different thinking. And like Dr. Bipin was saying, kidney diseases. So we get a lot of people with COPD, CKD, CLD, who are being identified often end stage in their 50s, and then you have very little time and there is not much that you can do. So how do we look to chronic condition definition, management, etc., which learns from the program but is not necessarily completely bound only by the boundaries that the program puts. One very important thing I just wanted to say, since you were talking about the NCD, is that with the Adivasi people, clearly the importance of diet and lifestyle and the way it impacts health is very well understood amongst almost every household, especially the elders, even parents, etc. This is the way they approach all disease conditions like this. So if some thinking and contextualization can be brought about in the program spaces, the acceptance and uptake and the compliance and the by the Adivasi people can be very good, given that they usually do not access such care anywhere else.
Thanks for sharing. And bringing the focus onto the specificities that programs are designed at scale for the entire country, but then there are these specific things that settings would require, and also the disease conditions that the program puts focus on versus what the local demographics and needs are could be quite different. Another question is on so you mentioned about the chronicity and how to tackle that, and a little bit from the population side. But if you could reflect a little on how prepared are our systems to tackle such long-term, chronic conditions and the care pathways that it entails.
Yeah, so I have the opportunity of in one of the ICMR implementation research programs at Chamarajanagar district level with our team, looking at strengthening Ayushman Arogya Kendras, or the health and wellness centers. And like Didi sir was saying, the NCD program is doing quite well in Karnataka through another research project called Impact NCD, going to intersectoral capacity building. There have been many small strategies that have come in and are being taken in very well. NCD program is really evolving very well. But one thing we see, since we come in from the broader health and wellness center, is that the work culture at the health and wellness centers, even at the PHCs, that everyone is very good at taking short-term problems. So if you have someone with fever, how do you deal with it? How do you get diagnosis, referral, follow-up? Very good. You bring in a new definition, a new program, immediately it gets absorbed. The other thing we do very well nowadays is the short-term high-risk conditions, like let's say a high-risk pregnancy or a TB patient. How do you follow them up, counsel, motivate? But you do it over a short tenure. And every year, this group changes. But the kind of approach in thought, in attitude and work approach that is required for continuity of care over life course, like what Dr. Bipin was talking about, that kind of thinking has still not completely become a part of the way the health and wellness center or the primary healthcare teams approach. They are still approaching NCD as a program. So because of that, I think that kind of shift in thinking, we are with the families, the same baby after 15 years is going to be our adolescent. After 15 years is going to be, how do you track, not track, but how do you keep in touch or, pay attention to people through their life journeys, family-centered approaches, knowing history. In this family, father had hypertension, this person may be at risk. So that kind of a family-centered approach or that continuity of care culture itself is largely the problem. I don't think the program seems to be doing quite well for whatever it is asking to be done. The other part, like so I was talking about referrals, that is the other big challenge for continuity of care, because in DOTS, if you see, the patient is diagnosed at a hospital, but the information goes back to the sub-center level as well. Person leaves one district, migrates to another district, the DOTS program, like the programs have understood how people behave. But with NCD program, it's still very much rooted to your house. And this is an age group which is working, which is moving around. They are for 30 years, you can't expect them to be available at that one place all the time. So learning about how do you ensure that, this book that is given to them is filled in by all the people and you have the records. I think so that the approach to life course or the approach to continuity of care, I think that's one of the big challenges. The other thing I just want to bring in here is all our programs, because we've also been looking at the data, the screening and coverage monitoring, what is called, is happening phenomenally. And by default, that is the focus of the government. But with ICMR, as we were working on this, we recognize that if you truly want to know if an NCD program is doing what it is supposed to be doing, you can't just say how many people were screened or how many people were diagnosed. You need to actually look at those who entered the program. Are they now in control and they feel they're in control of the illness? Are they getting whatever medication is required, or maybe they don't require, maybe they need counseling, maybe sir was talking about diabetic foot, so maybe they need some complication behavior. So are they in control? Are the complications not happening? That kind of data we don't have, because most of our programs are still connecting numbers, report way. So we actually don't have complicated indicators that tell you, for the people who come into the program, how many become in control, how many are uncontrolled, how many are actually following up, how many are complying by medicine. So we need more complicated information and a mechanism in the government or at the health facilities that is able to capture this kind of data, so that whenever you want to look at it, it is available. Sorry, my internet is down. The last part I just want to say is, and I just want to flag that through the Ayushman Bharat program, a lot of the NCD work at the community is tied now around the health and wellness center and the mid-level health provider or the CHO. In a state like Karnataka, where that question itself, like what is our vision with the Ayushman Arogya Kendra? Who is the CHO? How do we want them to do? All the NCD aspirations have been tied around the CHO, whereas the ANM is seen as someone who does, more the RCH work. So the program itself has gotten at the community level divided. So I think there's a larger question to also talk about how do we bring in this responsibility for chronic conditions, beyond a cadre or beyond a program, and make it a part of our health system itself. That's the last thing that I wanted to flag, Pragati. Thank you.
Sure. Thanks a lot, Tanya. And yeah, I think can't agree more. There are these multiple issues that we need to. I mean, we need those sort of indicators. We need to move beyond numbers and rather see, like I think both the DDs mentioned that it is people who are coming into the program. Are they ultimately getting the entire benefit of the program of controlling their NCD conditions. So one last thing, maybe if you mentioned the specific challenges and disease burden for the Soliga community, are there any attempts from your side or through the research that you're leading to tackle these specific challenges that you face at Chamarajanagar or at the district level?
Yeah, we have had conversations around it. I think our biggest challenge is numbers. Because the traditional ways of looking for research to build evidence requires numbers. I can talk about Jan Swasthya Sahyog in Chhattisgarh, even Gadchiroli. Like there have been places where JSS especially has developed a lot of case studies. They've put out a lot of data. Again, it remains hospital based only. And the question of lean diabetes, which now has been recognized, WHO just a few months back has labeled it type 5 diabetes. And typically age groups, more insulin dependent, and especially in communities where there is chronic malnutrition. But it appears when they are 18, 19, etc. So that now has also been acknowledged. So unfortunately, given that numbers is a big problem, like the hypertension I was telling you, type 1 diabetes in a population of 30,000, we are only able to diagnose maybe about 2 or 3 in a year. But we may be losing 2 or 3 children, we don't know, because they are not being diagnosed. So this kind of work really, maybe for NCD as well, and maybe it's an opportunity for us, is we probably need more long-term, like if you see cohort studies, right, like long-term sentinel sites, which are just tracking how these trends are progressing or not. For such kind of illnesses where the numbers aren't there, only that kind of research can do. So we are trying to set up a long-term monitoring site where we just keep capturing whatever information comes and trying to set it up as case studies. We're also trying to network with other sites where such cases are being reported and see if we could come together. But yeah, that's been a challenge for us as well. Thank you.
Thank you. Thanks a lot for sharing. And I'd also like to thank Dr. Bipin for engaging with the barrage of questions conversations that are happening in the chat box. I think it's great to see that engagement by the audience, and thanks to you for making the time to respond to that in between. We had also curated questions at the time of registration, and so maybe I'll pull up a few questions from there as well and link them to some of the chat that is already ongoing. So maybe one thing that we didn't touch upon too much is about this ongoing capacity building for frontline health workers. So how is that structured, and how do you assess its effectiveness? Like, is it working or not? How do you keep a track of that? So maybe I'll pose that to you.
Yeah, the training programs for the frontline health workers, like the ANMs, the middle level supervisors, the medical officers who are working at the periphery, the staff nurses who are working at the periphery, they all need to be trained, because every day protocols are changing, the developments in the field of medicines are changing, new diseases are coming in, new ways of diagnosing, screening, they're all coming up. So everything needs a training. So we cannot just start a program without a training up to the grassroots level. Even the ASHAs need to be trained or sensitized in every program. So we have a structured training program in Kerala. We have both LMS kind of training. LMS means learning management system, where the same training modules are explained by a specialist, and it is circulated to the entire workforce. So if any of the workforce is missing the hands-on training, they can get trained through the LMS system, and they can generate a certificate also from that LMS system. So what we do at the state level is we have a training group or the TOT group. So there are 4 to 5 people from every district. So whenever a new program comes in, whenever a new modality of treatment comes in, we will actually train these 70 people. That means we have 14 districts and 5 people from every district. So it is the responsibility of these 5 people to give a cascade-based training or a decentralized based training to the district or grassroots level. So that's the way we have been planning the training. And we have both the NP-NCD funds from the Government of India, and we have the state NCD plan funds. So using both these funds, we are doing the training at the district level. So LMS is also one key factor in the training program.
Thank you. Thank you for sharing. I think especially for these cadres where bringing everyone physically and, taking away from their time to put it up on LMS, make it accessible at their time and they are able to take it. That's also a great suggestion. And I think it's also one of the sustainable ways of doing it. So the training materials are there and people can access it as and when required. Now moving a little bit towards the NCD app. So if you can share a bit about what is the extent of usage of the NCD app, especially for this continuum of care, the life course approach. I think all three speakers touched upon that. So how is that app being utilized and is it helping with this? Maybe both of you can, yeah. So Dr. Bipin, yeah.
Yeah. So regarding the apps, there is a national level application for NP-NCD program, but unfortunately, our state didn't actually join with the national application because we had developed a state level application long before the Government of India came up with their own app. So we are using our own the state level app, which is developed by the eHealth Kerala, which is the digital platform for the health activities in Kerala. So right from the Ashas, we have the Shaili app. Shaili app means they do the population-based screening using the Shaili application. And that is a mobile-based application, Android mobile-based application, which all the 26,000 Ashas are using every day. So from that Shaili application, the data is transferred to the application at the Jack or the HWCs, where the MLSP, the ANM, and the junior health inspector, they all can access this data through a Janegiya Arogya Kendram app or the Check app or the public health application. This is again a mobile application. So the data which is referred by the ASHA goes to the application of the field worker, frontline field worker. From there, the screening data that will be transferred to the e-health system in the primary care system. So everything is connected right from the community level. The data is connected electronically through this e-health system. So it is easy for us for having an analysis. It is easy for us to generate a report because we don't need to go behind people for running after the reports and all. The entire reports can be generated from the backend from the e-health system. So that way, we can actually improve our program. We can actually find out the gaps in the program. We can actually see where the reporting is going back or where the program is lagging behind, where the control rates are low, in which district the hypertension control is poor. So like that, we will get an array of data through which we can have some kind of an intervention from the state and the district level. So that's how we manage the data, but it is not connected to the national data.
Okay. Tanya, any insights from your side on the Karnataka app usage based on the district level activities? Yeah.
Yeah, the NCD app is being used very well. And the NCD app, like we have looked into the kind of dashboards and the kind of even analysis that is available, the way you're able to track, etc. And it's actually quite good. I just like to share here a little bit about before the app came in. So in fact, this app was before Government of India brought it in, was actually part of a much larger app that was actually designed and developed in Chamarajanagar district for nearly 3 years, which sought to take all of the registers, all of the programs. It was a more integrated app with multiple modules where you would get information at the family level, but it would populate whatever the concerned program required, allowing the health worker to be a part of it. Unfortunately, when this big app, which is called CPHC, Comprehensive Primary Healthcare Management App or something, when it went, through the various iterations to Government of India, etc., the only part that they decided to take forward was the NCD app. So the integration with other departments, the integration with other aspects would have been brilliant. While the app does do what it does very well, the app information is largely not really meant for, right now, the way the dashboards are and the way access is, it's not really meant for the team on ground. It is more meant for reporting and reviewing and knowing what is happening when you're looking at the big picture of that neighborhood or that area. How many cases are pending, what is happening. So that is something that we are trying to now address in one of the implementation research we are doing, because ASHAs fill in CBAC form, like the family folders. But then after that, the family-wise data, what it is, if you want to retrieve it for something else, for another survey that has come or another program that has come, it's not locally, you're not able to retrieve that data. So permissions slowly are being, first it was only at the state level, then at the district level. So now slowly it is still evolving. But the app holds a lot of promise. Many of the district officers, even the taluk health officers, are utilizing it very well for reviewing and reforming the program. So it seems to be doing very well at the program monitoring level. But that individual continuity of care logic, I think that the app is still, still a little away from, and being able to be utilized at the level of care, that is also, it is a little away from. And I think the last thing, of course, is that whatever has been learned in the NCD app, other apps don't bring in the same level of analysis. So that is a missed opportunity as well. Thank you.
Thanks for sharing. I think very nice to hear both different state perspectives and how it's being utilized. Some pros, some cons, some of easy availability, access, and analysis. And yeah, so maybe one question that we've not touched upon so much yet is the issue of maybe mental health, and how are states integrating that. We spoke a lot about the other things like the diabetic retinopathy, the diabetic foot, the other allied issues. But if both of you can briefly share reflections on mental health and how that is being integrated along with the NP-NCD program delivery.
Adolescent health and the school health both holds an important key in the management of NCD control, because all the behaviors are developing at the school level or at the childhood level. So any change in behavior, any change in attitude, any issue with the mental health, these all needs to be tackled at the adolescent level or at the school level. So we definitely needs to integrate the national mental health program with the NP-NCD program for an actual control of the mental health for the non-communicable diseases, because most of these diseases are interconnected. Because stress is one of the most important reason for hypertension. Stress is one of the most important reason for diabetes. So stress can lead to heart diseases. So everything actually starts from stress. So, and a true integration between the mental health program and the NCD control program is very essential, and that should start from the adolescent group. That is the area where a lot of hormonal changes, where growth issues, a lot of mental health changes happen at that period, so that the focus of the mental health management should happen at the adolescent age group.
Thank you. Thanks. Tanya, thoughts?
Yeah, in Karnataka, unfortunately, in terms of programs, I think the importance is very well known, and it is important. And in many of the programs, school health programs as well, many of the events that are organized, this is also reiterated. But unfortunately, programs, they remain in Chamarajanagar district, for example. I mean, despite so many years. Some of the initial enhanced community mental health programs started also in Chamarajanagar more than in the late 90s. We are yet to have a basic district mental health program that is even functioning, even though we have a medical college as well. So I think the mental health program by itself, the team is struggling to just come into play, to be in place for a longer time. We have very high turnover of people. So I think as programs, there is very little that they are still able to do. NCD is a much more internalized and already part of the DNA of the public health system. But in terms of activities and importance, like Dr. Bipin said, I think it is very important. But right now there isn't much happening around that. So adolescent health focus, which has now emerged again, elderly focus, which has emerged, for example, these are again, so the health and wellness center concept has opened in a very loud and visible way the opportunity to bring these together. But at least in Karnataka, maybe except for a few pilots here and there that are ongoing, yeah, not much happening in this space.
Thanks for sharing. There are many more questions actually, but we are at time, so we just have the last 2 minutes. So I'm thinking that if there's anything as a closing remark that you'd like to share, something that has been done or something that you look forward to in the NP-NCD program, maybe we could end with that, and we'll keep the conversation going. Yes. So, Dr. Bipin, any final remarks, final thoughts, and then Tanya.
No, rather than going after so many diseases, we need to concentrate more on the diabetes and the hypertension part and the basic cancers, because these are going to be the growing epidemic in the near future. And the complications due to these diseases are going to increase more in this coming future. So we concentrate more on diabetes and hypertension and its control. And if we can attain a control rate of above 70 in the country, that is going to make this NCD control program a big success.
Thank you. Yeah. Tanya?
Yeah, I think, one thing in Karnataka very brilliantly that's happening is that the Panchayat department, welfare department, health department have really come together, like with the Griha Arogya program that Dr. Raghunandan was mentioning, have really come together in a very, to say that this is something we're going to tackle together. And the fact that health is now moving beyond departments' initiatives and becoming, coming into all programs is still limiting, though, I think, at least in the Karnataka setting, is that the focus is still around the diseases, just catching the disease or giving medicines. Like it's still a very patchy approach. Focusing, like what Dr. Bipin said about the life course approach. Are our spaces encouraging? Are our environments encouraging for, let's say, better walking, better facilities, good physical activity, mindfulness, stress relief? Integrating it into every curriculum, whether it's school, college, from primary to high school, etc. I think that kind of a health in all policies framing is something that Karnataka seems to be doing, but has still not fully arrived to. So I think that is really I would say the main way that the government seems to be going at it, but and also seems to be the right direction. Because like Dr. Bipin said, this is not something like TB and leprosy that we're going to catch with numbers and do. This is almost everyone in your community has some chronic condition or the other after they are the age of 40. So we can't be fixing this through medicines and hospitals. We have to find a more long-term and a more comprehensive way of tackling it. Yeah, thank you.
Thank you. Thank you so much, Dr. Bipin, Dr. Tanya, and to Dr. Raghunandan as well for sharing their thoughts. And a huge thank you to the entire audience for being so receptive, so engaging, and interacting with our speakers. So we'll see you in the next episode. And thanks again for being with us today.